Sabina today is going to give us her inaugural lecture, which has been postponed by 1 year. So I don't know whether you want me to read all this out. I mean, it's a 3-paragraph summary of a 100-page CV. So why don't we just summarize the 3 paragraphs into 3 words, and Sabina is brilliant and we will find out why. Sabina, good luck with a very good delivery. We're all here for you. And do take off your mask. Nobody else is allowed to. You can take off your jackets, but not your mask. And you know where the fire exits are. Sabina, please start.
So thank you all for coming today, and thanks to Christopher for introduction. I would like to have a special note of thanks to the Dean, Malcolm, Professor Reed, who helped and supported me in the promotion to professorship, and to previous head of the division for medicine, Professor Kevin Davis, who was my mentor throughout Brighton journey, and also to Professor Hugo Critchley, who is the head of neuroscience. So I had to have 2 approvals though, because my work is linked for the 2 areas, mostly for brain imaging, but also for huge area of cancer and inflammation. So I would start my journey with my parents. So they are not here. Unfortunately, my dad passed away, and he was also a medical doctor. And I heard these words every day in my house: education, education, education. So coming to England, it was quite coming home with Tony Blair at that time in charge. And the main motto about, having an education is something which we all need and deserve. So he was a psychiatrist, so I had a calm influence from his side, and he actually made me a person as I am, together with my mom and my brother, who were really influential in my life. My mom and my brother are joining via link from different countries. My mom is still in Sarajevo, and amazingly, she still works. She is emeritus professor of respiratory medicine. I visited Sarajevo just in August, and she was reporting X-rays of COVID patients. So I think that driving energy that actually somehow she implanted in me is still there, hopefully for some time to go. So you can see me and my brother looking as twins, although we are not twins. He is just 1 year younger, and he developed in a neurosurgeon, unfortunately, because of some work commitments and unforeseen circumstances, he couldn't join, but he's joining by link. So I want to thank them. They can't be with us. And also I want to thank you all coming today, all my friends, currently under masks. So that is a special occasion and a special effort. So I also want to thank all my friends that are actually somewhere in different countries in the world. And I know they should be joining from everywhere from the world, my colleagues and friends from childhood. So my declarations for different scientific consultancies, but there is no conflict of interest in this talk with any of them. And just would like to outline my talk. I would have 3 main themes through this talk. One is an introduction about my personal life and the profile. Then the second section is very brief because I would need to spend probably months talking about how nuclear medicine became unclear to clear to dear. But I would suggest Professor Ralph McCready's videos or reading his book, because that's something that would really give you better insight. And the third section would be about my research, which is entitled ABC, My Research and Teaching from Bed to Bench and from Diagnosis to Treatment. So I had a PhD in ABC imaging, and we'll talk about that later. So that is one of the aspects of the third section. And the second aspect is also ABC of my nuclear medicine research alphabet. Because we nuclear medicine physician, we actually really assessing total body rather than system-based very often. And it's really hard to decide in which system we would really want to concentrate on, although it's really important to focus in research. So I'm sort of finding myself still, but I think that this is a scope of my research, which I want to mention. I'll not mention everything what I do, of course, but something which I really think it was important in my life and development. So there will be several letters of alphabet, which I will be talking about different projects in my life. So with regards to my personal journey, I'm shaped by 3 countries, 3 cities, 1 war, and now 1 pandemic. So I was born in Yugoslavia, which is ex-country, and virtually now dismantled in the several countries, which Bosnia and Herzegovina is one of them, which is my home country, and the Sarajevo, which is a city where I grown up and had my primary, secondary education and graduated at the medical school. And then United Kingdom, which is like my new home. The story about that is that when coming after the war in the UK to do my International Atomic Energy Agency, MSc, coming back from my first conference, I actually was greeted by Professor Peter Jarrett, who was a professor of physics at UCL, and he was my mentor for International Atomic Energy Agency Fellowship. And he told me, welcome home. And I really felt like, yeah, this can be my second home. Although I did travel before throughout Europe, I never felt like that. So this is me as a child. And clearly my passion about bags remains. And this is Sarajevo, and coming back to Sarajevo this summer was special because we saw our families after 2 years of pandemic. And I know this pandemic affected all of us. So I think we are moving forward, and hopefully we'll be having a better time in the future. And that influence that had on us, that will be forgotten soon, as Christopher mentioned. So my personal profile, I'm consultant nuclear medicine physician at Brighton, Sussex University Hospital, now renamed to University Hospital Sussex since 2003. Appointed as a lead consultant to start with, actually head of the department, and Professor Bascom is in audience, and he was on my interview panel. So thank you, John, for coming today. And thank you for appointing me to this fantastic job. So principal lead consultant in imaging since 2014. And this, for me, was always natural to combine my clinical work with academia. I've been always inspired by my patients and clinics, and I think my ideas actually matured with my age as well. So activities at medical school, I'm PET-CT clinical lead at Clinical Imaging Science Center since 2007, chaired of the Clinical Imaging Science Center Clinical Executive Group and member of a CISC management group. I enjoy my teaching, and I love undergraduate teaching, particularly IRP projects, individual research project supervisions in year 4, and being personal tutor for medical students from year 2 to year 5. With regards to postgraduate teaching, MSc teaching internally and externally in dementia studies and oncological imaging, and also as external examiner at the KCL MSc in nuclear medicine. I'm involved with as examiner for PhD and MDs, and also had the postgraduate teaching of many academic F2s, supervision of nuclear medicine clinical research fellows and SPRs. And some of you are here, and thank you for coming tonight. So these are all some of the awards of my trainees that I'm very proud of. And some of them are really special, and clearly as a mentor, it's important that you keep contact with your trainees. And particularly, I don't want really to point something, but I do need to point Dr. Vale, who is here tonight. And that was one of the first projects that we win a prize for the most competitive prize for the Young Investigator Prize. And she was also a student in medical school. So that is same medical school as Brighton Medical School, which was more special. So another medical student as well winning the Young Investigator Prize, probably as a first winner as a medical student ever. So basically moving on from awards to my dear nuclear medicine and how that became clear from unclear. It all started with the discovery of spontaneous radioactivity in 1903. And we are using different classes of ionizing radiation in treatment and in imaging, in diagnosis. In nuclear medicine, we use alpha and beta minus emitters for treatment and gamma and positron emitters for imaging, for diagnosis. So nuclear medicine is defined as a specialty which embraces all applications of radioactive materials in diagnosis and treatment or in medical research. And it is application of tracer technology to medicine. So this is for benefit of my friends that are outside of medicine, just to describe a slight difference between clinical radiology and the nuclear medicine, because clinical radiology instrumentation induces signal changes and detects effect, while in nuclear medicine, our patient becomes source of energy. And this is imaging as inside out. So it's a truly functional imaging. And the beauty of nuclear medicine is an fusion between diagnosis and therapy. So it is so-called theranostic or theragnostics, which combines diagnosis and treatment and also allows us to monitor response to treatment and predict treatment response. First rectal linear scanner was discovered in 1950 when we were actually possible to start imaging with a radio tracer activity, but images were really unclear. So with courtesy of Professor McCready, I'm displaying this slide, and as you can see, a hand looking really unclear. We have to even draw around, and Professor McCready is scanning a patient next image, bone scan, which was a little bit clearer, but still not completely. And interestingly, this is the same isotope which is now used in imaging bones for positron emission tomography, and also same isotope, which is a main isotope for labeling FDG, which is main radiopharmaceuticals used in nuclear medicine. So we didn't have equipment. We couldn't catch all the radioactivity. So through the development of gamma cameras, then SPECT cameras, then PET cameras, and then SPECT CTs and PET CTs, nuclear medicine became clear. And you can see images are really crisp and beautiful. We can see entire body in one image. And why it's actually now there, and to many outside of nuclear medicine, and also to our referring clinicians, because it was eye-opening. Once when we actually developed multi-modality imaging PET-CT, our first clinical operational PET-CT was installed in 1998 in the University of Pittsburgh. Everyone could see abnormalities that we could pick up much before anatomical changes were visible. So CT of the pelvis, completely normal. PET image of the pelvis, definitely there are some blobs, we call them hotspots, but we can't localize them. But when we have a both, we can localize those changes. And also, actually, this was PET-CT guided biopsy proven lymphoma. And it does help to change the patient's management and to implement right diagnosis. So anatomical imaging can't see everything. And very often functional imaging is a choice of which can help to find the cancer or find the neurodegenerative disease, because sensitivity depends on magnitude of metabolic change rather than size. However, some changes might be really metabolically low active, and then we see them better on anatomical imaging, although the most cancers are not, but there are some metabolically inactive cancers as well. And then structural imaging helps not just with the localization, then with the diagnosis as well. So it's really important to assess both. So nowadays we are using multi-modality imaging, which did make nuclear medicine really popular. So I just want to show one image of a new tracer PSMA, which we started this year in Brighton as well, a prostatic specific membrane antigen tracer, which is used in, for diagnosing prostate cancer. And you can see how clear pictures are. There are definitely absolutely lovely images. And we can assess entire body. We can go through all slices of the body. And in this context, we immediately can see that there are two little lesions that are not normal. In nuclear medicine, it's really important to know normality, to know normal distribution. All these areas that are actually looking really dark, they are actually normal because they are normal distribution of PSMA. So this was a biopsy proven, that was histologically proven a nodal disease. Coming back to molecular imaging, which is actually not new to nuclear medicine and been used in nuclear medicine for 80 years now. So it is a truly imaging at the molecular level. So typical example is imaging thyroid gland. Then tracer that we given is iodine, or we give an analog, which is a technetium pertechnetate, which is taken by the cell membrane by sodium iodide that's imported, organified into the cells. So nothing else can be more functional than this. And birthday of diagnostics was actually 80 years ago, but we only started calling diagnostics just recently. So Seoul Health administered cyclotron-produced mixture of beta emitters as a first therapeutic activity to human patients with the Graves' disease. And ever since we are using radioiodine treatment, it's 80 years of treatment. It's probably aspirin and maybe very little other drugs are still in use after so many years. And diagnostic associate both of diagnostic tests that identifies patients most likely to be helped or harmed by a new medication and targeted drug therapy based on the test results. In nuclear medicine, we have a different ways of applying diagnostic. So we have a diagnostic imaging with the same isotopes with different energies, like for example, with the thyroid, when we use gamma emitters to image thyroid, but also use a beta emitter, iodine 131, to treat thyroid disease. We also use the same peptide, but different labels, different radioisotopes. So we use a gallium-68 positron dotatate for imaging neuroendocrine tumors, or PSMA for imaging prostate tumors, but we also use lutetium, which is beta agent, or other alpha agents that can be actually used in treatment of these same tumors. And the third mechanism is that we have a similar mechanism of action, but different element isotopes, such as, for example, bone scanning with the technetium diphosphonate or 18F sodium fluoride, but we're treating those patients for bone metastasis with the radium or strontium, which have a similar mechanism of action. So beauty of nuclear medicine is in diagnostics. And I remember when I was a fellow with ISTI and thinking maybe to do pediatric medicine, although now we have a pediatric tracers, pediatric agents, and ISTI was also always very wisely telling me, what's about your therapy? So I think therapy times definitely did come. So diagnostic being in use for thyroid cancer, but also for thyrotoxicosis. You can see here there is a really area which is abnormal, which becomes completely different after we treated with radioiodine treatment. So this nodule, which is really over-functioning, became non-functioning nodule after treatment. So this patient is cured. This patient is not cured, but it's continually treated with our treatments. And the new treatments on horizons, hopefully next year, will be approved by NICE and in clinical practice for prostate cancer patients, imaging patients before treatment with the positron tracer treatment dose 1, 2, 3, and you can see how these lesions disappeared. So clearly response is not always so brilliant, but most of the patients actually responding to this treatment. So I'm moving from this to my third section, which is ABC research. And my research from bed to bench and from diagnosis to treatment, because I do have aspects which actually from bed to bench as well. And although my primary research was in patient focus. So this is a department of endocrinology from Sarajevo, and I'm here as a young junior doctor, just graduated from medical school, University of Sarajevo, and I was always good in school, so I can't lie, I wasn't, so it all went very well with the schooling. But then war happened, and I started doing my medical training and rotating, having shifts every 3 nights on call, but also working as a part-time for NGO, non-government organizations, helping war amputees. This project was called Hope for Sarajevo. And I was asked, do I have any pictures? I was thinking, oh no, I really didn't think about taking pictures. I did actually ring my friend, one of my best friends from Sarajevo, Professor Strauss, who is now Professor of Anesthesiology, who was the leader for that project. And she looked everywhere, she couldn't find the pictures. But I did have one picture of a wood burning stove, which was what we used during the war. We didn't have any electricity, no water, virtually we were freezing. So we did manage to get this improvised heater, but we didn't have a wood because we lived in the city, there are no woods, and basically we had to burn things, whatever. Fortunately, my mom and I had a lot of shoes, this is true. So, and also by some, I think I was really exceptionally lucky during the war that, I wasn't really injured, wasn't killed, but I had a really terrible incident when I was almost killed, and we had all these motor sharpeners coming from the in the city, and virtually they were making the roses on the street. And nowadays these roses are filled with the red, so they actually are something to remember. But everyone moved on, and this is the rose from my mom's garden in her country house, which is a wild rose from Sarajevo, and I truly prefer this one. So it was a definite hope for me when I met people from International Atomic Energy Agency, visitors who came to Sarajevo to visit nuclear medicine, asked me what we needed, and I said we needed nuclear medicine specialists. And they told me, oh, you could apply for this fellowship. And then I said, oh, excellent. So I applied for fellowship, and I had a chance to put the choices. So my first choice was London, then New York, then Stockholm. It was that I did read a lot of Jane Austen, and it wasn't because of Mr. Darcy coming to England, but I really wanted to learn from the best. And I really thought that at that time, England had the best nuclear medicine physicians in the world. I got a fellowship at UCL, and that was my supervisor, Professor Durval Costa, chosen fellowship, my MSc project in brain imaging. So that was using 1,2,3 iodine for ibuprofen, which is now called DATScan, which is analog of cocaine, and virtually behaves same as the cocaine, but we give it in very little tracer doses, tiny doses, so it can't have effect. That did shape me as a nuclear medicine physician. It was a hardship. I was learning with half of my brain. English is my second language. And, but I studied 14 hours a day. So basically, this was my MSc thesis, which then started using quantitative analysis. We had to draw everything manually. But nowadays we have numerous softwares for quantitative analysis in nuclear medicine, and this traces used in Parkinson's disease diagnosis, and this is how our basal ganglia should look, and this is how they look if someone has a Parkinson's disease. So this is dopamine transporter analog, and it's actually labeling availability of dopamine transporter, which is deficient in a Parkinson's disease. So true molecular imaging. I can't go without mentioning our dear friend, Dr. Mira Blackson-Thomas. She was my examiner during MSc, and she did like my project. So we became really friends, and unfortunately she passed away, but she was one of the inspirational strong women who did fight for nuclear medicine. And she was acknowledged at the 500 years of women in medicine at Royal College of Physicians celebration. Further inspirational model is Professor Val Lewington, who continued with this MSc. She is very passionate about enthusiasm for subject and to pass on knowledge and skills. So I think it's important that this MSc continues and producing new nuclear medicine physicians. So my long-term mentor is a Professor Iski Gordon, who is here, and thank you, Iski, for coming tonight. So he was a leader and founder and champion of pediatric imaging. I was offered Andrew Beckler Fellowship after I came back to Sarajevo, after I finished my MSc, and then established many nuclear medicine procedures in Sarajevo within 1 year. I was asked there, what did they do to you? Why are you staying so late at work? Anyway, so basically I did learn that child is not just a small adult, which helped me with my son. And yeah, that's us, and that's me, rather heavily pregnant. And I learned about real work ethics, and high quality of imaging is essential. There was no way that if there is some image which is not good quality, that could pass is key. So share ideas and good practice is important. Objective setting is essential, and to build up on excellent work and share our knowledge. I did work with the best, and I think this is my life, and I wanted to acknowledge everyone, and I hope I didn't forget anyone. I mean, I didn't forget, I just didn't have time to put everyone on, but Professor Maisie gave me first consultant job in the UK, and that was actually advanced training in PET as well. Started as a clinical lecturer and honorary consultant at Guy's and St. Thomas's, and I learned about PET a lot. He brought PET in the UK. So worked with the other big names in nuclear medicine, Professor Ines Fogelman, who is unfortunately not with us as well anymore, Dr. Clark, Julie Martin, and Professor Bailey. So moving during this time in Guy's, I had a lot of publications, but I really didn't want to talk about them in details. And I continued my interest with pediatric nuclear medicine, published GFR in children paper while I was at Guy's. But then there was a job in Brighton, and I moved to Brighton. I got a job, and I was appointed as head of the department. We had 3 cameras at that time, but only 2.5 used. We had only me and my predecessor. Now we have a fantastic team, and thank you, team, for coming tonight. And we actually conducted more than 150 multi-center commercial industry sponsored projects. And also we had a lot of in-house research, which is really great. And I'm sorry that Scott couldn't come today. And he told me that, yeah, he's really proud what he did. And with not many resources, actually, because that was a developing process. And it's actually, there is a passion there to build infrastructure. Sometimes it's much better than if you have everything just given on your plate. So special thanks to Professor Davis, who actually was one of the pioneers in using PET in large vessel vasculitis, IgG, and all unusual rheumatological and immunological conditions in Sussex. So we also did a lot of other PET-related projects, which were in different cancers, changing management of patients. I listed some of them, and actually some of the references were used to change the guidelines. We conducted a lot of dementia multi-center trials and had a conventional nuclear medicine and nuclear cardiology as well research. So during this time, I was thinking I'm really doing a lot of research, and I really wanted to do a PhD always. I had a plan for the program, and Professor Peters was here, and he supervised me in my thesis, which was called Imaging Physiological ABC Transporters Expression and its relation to disease using MIB, which is technetium-99 hexacis methoxyisobutylisonitrile. So clearly it was one of my very special days in life, and I was awarded PhD by our Chancellor, Sanjeev Bhaskar. And that is a bit of my research, which is called ABC. ABC transporters are ATP binding transporters, and they are responsible for multi-drug resistance and toxicity. So they can detect toxicity in vivo, and they can detect multi-drug resistance. And they are also genetically driven. So they are encoded by genes that are called ABCB1 and ABCG2. Clearly, they are not the only reason for us to have a problem with the toxicity or multi-drug resistance, but they are quite important. And if we have 3 different genotypes, apparently, there are people who have a high expression of these transporters, and they will be prone to multi-drug resistance. Other people who have a low expression of these transporters will be prone to toxicity. And if it is average expression of genes, then you might be fine, but you might develop one of the other. So actually it's important to image in vivo, although we can assess genes, we can assess actually transporters availability, but it's important to have epigenetic imaging and see how they behave in human. So I use MIBI, which is an old tracer, which is a tracer gamma emitter labeled with technetium-90M. So it was a gamma emitter, not PET. And we were looking really for role of MIBI in a transplantation setting. So I think did a kinetic on MIBI for renal kinetic, hepatic kinetic, and also looked for the genotyping correlation with the imaging. And I had a really great help from Professor Melanie Newport, who was guiding me in genotyping in this context. So we did show that pharmacological blockade with cyclosporine alters MIBI kinetics. So we could potentially use MIBI for following patients and who could potentially develop toxicity or the resistance. But also there is a signal that MIBI kinetics appeared more influenced by some particular gene, SNP3435C more than T, and while pharmacokinetics influenced by drug is influenced by other genes. So basically, it was quite unusual and a difficult area, but I think it's something which we definitely should go back to, because with personalized medicine, we will need more of this type of studies. And this PhD was actually used for predicting, for platform, for developing further imaging assays. So for predicting drug-induced toxicity, for predicting a response to treatment and multi-drug resistance and correlation of imaging results with genotyping. So from this, I actually moved to the group, which was formed between UCLA and Austrian University of Austria, which is a collaboration with industry. I was virtually approached by CEO of Avant, who is very visionary about potential use of the different radiopharmaceuticals, and used as a clinical scientific advisor, but we managed to develop a PET tracer. So PET tracer is now developed, but which is dual ABCB1, ABCG2 substrate. So this tracer would be really good for use in a neurodegenerative disease, but also in imaging multi-drug resistance in tumor. However, COVID happened, so the human studies that were planned were currently delayed. And this is a mice image. The group of mice was imaged by this tracer and clearly showed if wild type mice has a really high expression of these transporters, the blood-brain barrier would not allow transport to the brain. While if this in knockout mice, these mice, they don't have any more ABC transporters, the tracer goes to the brain. So basically, we also use a different blockage with the taripidar and the docetaxel as well, and to prove that this is an ABC transporter analog. And I'm hoping that in the future, this tracer could be used in different clinical settings, as I already previously discussed all of them, or some of them. But it takes a long time for tracer to be available routinely in clinical practice. So I just moved to the last section of my talk, which is ABC of nuclear medicine alphabet. So these are my other research projects that I was going through or conducting or leading on or having some of the roles, important roles. One is main of them, I would say, is a use of alpha emitters in clinical practice. So it's 110 years of radium. It's not the same radium as Marie Curie developed and discovered, but without that radium, we wouldn't have this one, because actinium-22 source was also produced by neutron irradiation of radium-226 in a reactor in order to produce radium-223, which we are using in clinical practice. And after being, as a part of a trial, which was called the Simca trial, which showed that this radium actually increased survival in metastatic prostate cancer patients, we were one of the first clinics really in the world who actually started treating radium patients in clinical practice. So alpha emitters causing a double breakage of DNA, and therefore they are more powerful than beta emitters in the treatment of cancer cells. And some of my publications about radium, and one of them actually was selected for Marie Curie Award in 2017. That was our third selection for Marie Curie Award from the department. Previously, we had one trainee selected, and Mariam, who is here, who is our advanced practitioner, selected for actually idea about having advanced practice in nuclear medicine from radiography background. So I think that she was the first advanced practitioner in radium treatment in the world. So I think that was something as a changing management of the patients in clinical practice. So another award-winning, actually, Best International Abstract Award 2019 was a presentation at SNMMI annual meeting for co-treatment with radium and enzalutamide combination treatments in clinical practice. So I was a lead author for the first interim results of radium-223 reassure trial, which is a multi-center trial for safety analysis of radium, analysis of patients' characteristics as safety by prior use of chemotherapy, with 150 centers involved, and clearly showing that radium is safe in a clinical practice, and that drug-related hematological effects are actually not prominent, and less prominent if radium is given as a first-line treatment, rather if it is given after chemotherapy. So it's important to look for impact on patients' outcomes, and we know that now commissioners are asking us to produce that as well, because in the past they asked to produce impact on change in management. So we did look on patients' outcomes in our own clinic in Brighton, and we showed that our collaborative multidisciplinary referral pathways, together with increased experience with radium, led to improved outcomes. We also identified biomarkers such as alkaline phosphatase and alkaline phosphatase dynamics that can be useful to monitor response and predict overall survival as well. So A is for apoptosis, changing a subject. This is something which is unfinished work and which I truly wish to go back to. And I think we will one day. We have a group of chemists at University of Sussex that were looking into this. Idea is that we actually produce radiolabel apoptotic probe, which can be vehicle for novel multimodality radionuclide chemotherapy. So firstly, we induce apoptosis in the tumors by radiation, and then we inject radiotracer, which could deliver additional radiation dose, internal radiation dose, but that agent needs to be apoptotic agent. We identified molecule that we thought that it could work, but we have some difficulties, but idea is still there. So moving to B for brain imaging, a lot of different applications of tracer technology to neuroscience, and all of them are currently applicable in clinical practice. So we are using all of them. We don't have funding from NHS England for fluobetapir, fluobetapine, and flumatabole, which are amyloid tracers, but we have a really excellent group of clinicians and scientists in neuroscience here who actually, some of them even managed to find some local funding to use for amyloid for clinical purposes, such as, for example, Dr. Rezak. So one of the projects that I mentioned, which is, I think it's really important to be proud of your trainees, and it's just their success is something which makes me extremely happy. And this is a project which was from a medical student looking for relationship between emotional dysfunction and self-reported impulsivity in patients with Parkinsonian syndrome. And these preliminary findings that we showed were actually really relevant in clinical practice, because it could be helpful to differentiate Parkinson's syndrome from so-called scan without evidence for dopamine transporter deficit. So the idea is that to look whether we can identify patients who are susceptible to impulse control disorders, and larger studies are now required. So the question still remains, can baseline DAT scan in drug-naive patients predict development of ICD? Dementia is within B word, but it's very, very important letter, which I think is now becoming even more fearsome than C word for cancer. So basically a lot of projects and a lot of plans, a lot of collaborations, and amyloid-sponsored trials, FDG trials, a really exciting area. And there is a tau development, but we actually started doing that before COVID, but we were interrupted. And one of the areas that we are really good in the group is Lewy body dementia and a neurocognitive impairment in Parkinsonian syndrome. And also in HIV patients, because HIV can go with the dementia as well, although with the HIV treatments is now less common, but there are a lot of different levels of cognitive impairment. It's not completely dementia, but dementia still can be present. So most recently we published a paper with Dr. Vera together when we use amyloid scanning to basically help in diagnosis of cognitive impairment in people living with HIV. So I'm hoping to finish soon, so getting towards the end, but please be patient. It's just a C word now with the cancer and cardiac imaging, and clearly with nuclear medicine, cancer is one of the main areas of research and the main areas of clinical applications. And one of the projects that I put on is an NIH-funded project with Professor Gilbert as a chief investigator. I was a PI for Brighton, and currently we are waiting for review for the main cost effectiveness of dynamic enhanced CT versus PET-CT to be published. But so far we published impact of solitary pulmonary nodule size and quantitative assessment using fluorodeoxyglucose PET. When we actually established new cutoffs for SUV max, because it was established for a long time in the nuclear medicine community, although we never took it completely as a definite, but 2.5 cutoff was a considered cutoff for malignancy. We definitely showed in this prospective study that the cutoff depends on the size of the nodules. The smaller the nodule, the lower the uptake is actually required to be as a cutoff for malignancy. And this context for the nodules that were less than 12 millimeters, cutoff was 1.75, which is actually far below 2.5. So one study that I want to mention related to thyroid and thyroid cancer is a study from Anita Vale, who is here somewhere. Thank you, Anita, for coming, and thank you for this brilliant paper, because after this we had actually there were a lot of publications with collaboration with Mr. Zamit and Dr. Queen, and we have shown that using a MIBI, we can actually reassure patients if there is a MIBI matching appearance with the pertechnetate. So basically, if MIBI is negative, then there is only 3% chance that patient has a cancer. So, and this has also gone to cost effectiveness analysis, and we also demonstrated that incorporating MIBI in a pathways can be actually cost effective in complex cases. So more recently, I led on this position statement for World Association of Radiopharmaceutical and Molecular Therapy on initial radiotherapy for differentiated thyroid cancer, because there are some recent controversies in thyroid cancer management, and which actually demonstrated the importance of having prospective trials, because radioiodine was introduced 80 years ago. We didn't have a prospective trial, so now it is actually exposed to criticism as well. But Society and World Association statement is that we actually think that the demonstration of iodine avidity and cancer spread using radioiodine scintigraphy represent the core principle of radiodiagnostic approach that should guide personalized management instead of relying on less of direct evidence for disease risk. And size might matter, but that's not most important determinator of risk. So cardiac imaging, we also had a good cardiac imaging studies, but more recently I am less involved in cardiac imaging. But we had a previous collaboration with Dr. James and the Professor De Belda, which was really impacting clinical practice and was correlation with CA results, coronary angiogram results, and myocardial perfusion scintigraphy, when we actually detected more defects if we imaged earlier. There is one study which is still ongoing, and it's with Professor Bagar Yusuf, which is using myocardial perfusion scintigraphy in predicting cardiac risk prior to AA repair. We probably have a huge data. We do have a huge database, and we actually presented many times, but now it's time to write it up. So we have a currently fellow who is looking into this. So at the end, it's I for inflammation infection. I already mentioned our previous involvement with infection in inflammation, and clearly impact of COVID is something that we've been all struggling with, and nuclear medicine had the major disruptions with delivering services, but we actually did a survey and presented learned lessons, and we know how to deal now with the backlog. We're sharing experience between the departments, and more recently, as a collaboration between BSMS and University of Sussex, Imperial College, Cambridge, University College of London, and 11 centers from nuclear medicine, we submitted a grant for total body imaging of COVID in long COVID. Clearly, we don't know whether we'll get money. We are hoping we would. It's just first stage, because current COVID scanning is mostly concentrating on systemic scanning, while we think that we need to look interplay between organs. And we have also Professor Critchley, who is a main area in that sense. So basically, we managed to get collaborators from Imperial College to do all immunology tests. So we are hoping that we might be successful. If not, we might need to look for funding somewhere else. So my plans also to continue neuroscience research at CISC and continue with the therapy, because radium was a smart bullet for the proof of principle for further targeted alpha treatments. And as a chair of Intercollegiate Standing Committee, currently we are reviewing PET-CT guidelines for UK, and hopefully we'll publish that beginning of next year. And as a BSMS research lead, we are also planning to publish a BNMS research strategy. So ways forwards, it's amazing journey, and it's been like really, I've been privileged to witness all these changes in technology, and also changes in new tracers and the new knowledge integrated with the existing evidence-based and building up on new evidence base. So as a key message is, I would say this is a long, challenging, but rewarding journey, and I enjoyed it. It was hardship. It was shaped by many people, and we do need sometimes just raise as a phoenix from ashes. Whenever it's difficult in our life, we just need to move forward and live life in full. Teamwork, collaboration, teaching, fusion of high quality clinical work and academia are prerequisites for high quality of care and services for our patients. So I think that due recognition is not just courtesy we owe people, it's a vital human need. And I'm sorry if there is someone who is not on the list, but I really think I had all of you that in this theater that I collaborated with, and I had many friends. So I even didn't try to do like a list for national and international collaborators. I started and I thought, I know I can't do that. But I do want to acknowledge again Professor Reed and Professor Davis, and clearly our president, Professor Christopher Liu, who is chairing this meeting. And thank you all. Thank you to my national and international collaborators. As I said, I just decided to put few images British Nuclear Medicine Society is a national society which is actually, as our treasurer said, before you know it, those colleagues have become friends. I really think that being in a community, which is relatively small, but exciting and developing, is very rewarding. And a special thanks to nuclear medicine team, imaging team, and at University Hospital Sussex, and CISC, BSMS, lead consultant Dr. Singh, and everyone else here in the department from nuclear medicine, and special notes of thanks to Louise Abrahams, Kate Hopkins, Katie, and Denzel for arranging this meeting. And last but not least, I really want to acknowledge my cats because they were truly doing this presentation with me. I just was thinking what's going on with them. But then my husband, who is really supporting, and without him, I surely couldn't be here. And he is truly my advisor in life, and my lovely son, and that I just ask him to keep smiling. And thank you all.
Waqar, you want to say a few words? Is that right, Waqar? Would you like to say it now?
Thank you, Chris. Yes, Sabina, I just wanted to highlight your lecture was very inspiring, enlightening, and the amount of research and academic work you have done is phenomenal. But what I want to acknowledge as a colleague is that your clinical commitments and clinical excellence perhaps surpasses, if it's not as significant as your academic contribution. And as a vascular surgeon looking after patients with aortic aneurysms, I think there are many, many patients in Sussex who have benefited from an excellent service that you provided and developed to help us with pre-operative and perioperative cardiac risk assessment to maintain a good outcome for them. So your clinical work and support to other clinicians across the trust in different specialties is something that really deserves to be acknowledged and highlighted. So thank you very much on behalf of my department and all my patients.
Thank you, Waqar. Thanks a lot.
Sabina, on behalf of everyone who has listened to your inaugural lecture for your honorary chair, both those who were present in person and those who joined online and those who will subsequently see the recording. And on behalf of the MedChi, on behalf of colleagues from Brighton and Sussex Medical School, on behalf of your NHS colleagues, hundreds of students and thousands of patients, I would like to thank you, not just for your inaugural lecture, which was wonderful, but for everything you have done. Inaugural lectures are, I think, one of the most difficult to give. Your audience includes colleagues, friends, experts, mentors, and your biggest fans, of course, and perhaps your biggest critics, family. Your lecture needs to include your personal story, which in your case it did, and it was very moving. It includes your professional journey. It includes your tribute to inspirational role models. It shows your passion for discovery and development and for your clinical practice and your scientific exploration. An inaugural lecture needs to both interest, impress, and entertain. And I think I can safely say that you managed all these with visible commitment, and you are indeed an inspiration to everyone here, to your colleagues, both now and in the future. And I thank you for everything you have done. Congratulations, Sabina. Professor Sabina Dizdarevic.